Hello, everyone, and welcome to Cardiology Rounds with Drs. Julie Debakey and Mary Roman. We are getting started here in just a second. I just wanted to introduce myself. My name is Angela Christ. I am the director of the Loeys-Dietz Syndrome Foundation and the director of marketing with the Marfan Foundation. And with me today, I also have Susan Leshin, who will be helping us out in the chat. And we have both Dr. Debakey and Dr. Roman with us here on to present. So I want to invite both of them to hello.
Hello everyone. Yeah, happy to be here. I'm Julie Debakey, and we will be sharing some information and questions with you. Thank you.
Mary, I think you're on mute.
Sorry. Okay, so I'm Mary Roman, and like Julie, we're very happy to be here and hope that we can answer as many of your questions as possible.
Okay, so we are so thrilled. I see more of you coming in through the chat or through the app. Sorry, not through the chat. And as we get started, I just wanted to say how thrilled we are to have you participating in the International E3 Summit, which is brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS Movement, and also our partners in Europe at the CERN. We are so grateful also to our presenting sponsors, Brigham and Women's Hospital and American Communication Construction. Before we start this presentation, I just want to let you all know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation. Today, we are so fortunate to have Dr. Julie Debakey here to present along with Dr. Mary Roman on cardiology rounds. Following the presentation, there will be plenty of time for your questions, although I will note that many had been submitted ahead of this presentation. And so our speakers have prepared a very robust Q&A already with questions that had been submitted ahead of time. But if you have questions that come up, please do enter them into the Q&A section for this session in your app. So whether you're viewing on a mobile device or a laptop, there's a chat area, there's a Q&A area, and that would be where you would either want to add your question or you can upvote questions that are already in there that are maybe the same or very similar to what you would want to ask. We will do our best to answer as many of these questions as we can, but we can't, because this is such a popular topic and so many have been submitted, we can't promise they will all be done. But if you need clarification or would like to speak in for further depth about your question, you are always encouraged to submit your questions to marfan.org/E3ask. Now we will hear from Dr. Debakey about, with an overview that will help us set up the Q&A section of this presentation.
So, dear all, welcome to this online cardiology rounds session, which is part of the E3 Summit, organized by the Marfan Foundation together with the European Reference Network for Rare Hereditary Vascular Disorders. My name is Julie Debakey, and I will be starting this session with a recorded brief introduction. And as you will see, not all issues will be addressed here, as we will then continue with replies to questions which have been prepared by the various patient organizations. As most of you will know, cardiology plays an important role in the setting of Marfan syndrome and related genetic conditions of the aorta. Cardiovascular evaluation is required for the diagnosis of cardinal features being aortic dilatation or dissection, as well as for mitral valve prolapse with or without regurgitation, which is part of the systemic score. Once diagnosed, all patients with Marfan syndrome or related conditions require lifelong treatment and follow-up, guided by the cardiologist. Now, the cardiovascular manifestations that we would like to briefly address in the next few minutes include aortic aneurysm, aortic regurgitation or a leaky aortic valve, aortic dissection or a tear in the wall of the aorta, mitral valve prolapse, and mitral valve regurgitation, or again, a leaky mitral valve. Before addressing the specific diseases of the aorta, it's important to have some notion of the anatomy, which is illustrated in this picture. The aorta is our largest blood vessel, transporting oxygenated blood all the way from the heart to the rest of our body, starting at the valve with the root and the important sinuses of Valsalva, which are a slightly enlarged portion where the coronary arteries branch off. And then the vessel goes up in the thorax with the ascending aorta, and then we have the aortic arch with the head and neck vessels branching, the descending thoracic part, and finally the descending abdominal part with branches to the various organs in the abdomen. Now, to explain the terms aneurysm and dissection, we will focus a little more on the thoracic part of the vessel, as these are most commonly affected, though not exclusively, in patients with Marfan disease and related conditions. As shown here, you can see that the aortic root on this picture is enlarged or dilated. Here we go. And when the enlargement exceeds 50% of a normal diameter, we call this an aneurysm, in this case at the level of the aortic root. Aneurysms typically do not cause any symptoms, but they are dangerous, as you can imagine that with growing size of such an aneurysm, the tension in the vessel wall will gradually increase, which may eventually lead to tearing of the vessel wall, which is then called an aortic dissection. An aortic dissection is an acute event causing severe chest pain and very often also back pain, along with other manifestations according to the branching vessels that are involved. When this happens in the proximal or ascending part of the aorta, this is called a type A dissection, which is a surgical emergency with high mortality rates. In case the dissection occurs in a more distal part of the aorta, so beyond the arch, we call this a type B dissection, which is usually treated medically in the initial phase. Mortality rates are lower, but morbidity is still high, which makes it a severe condition that needs to be prevented. Now, as I mentioned in the previous slide, the common classification of aortic dissection is the Stanford classification, distinguishing type A starting in the ascending part of the aorta and type B dissection starting in the descending part, as shown here on the right panel. Another classification system is a Debakey classification, further distinguishing the type A dissection into a type 1, where the dissection extends all the way down to the descending part of the aorta, and type 2, where the dissection is limited to the ascending portion, as shown in the middle panel here. So what are the main risk factors for developing aortic aneurysms or dissection? By definition, genetic aortic diseases are a major risk factor, and unfortunately, many dissections we see occur in patients who were not aware of the diagnosis prior to the event, indicating that we still fall short with respect to early diagnosis. Age plays an important role even in normal people, since the aorta widens with age, and this process evolves at a much higher pace in patients with Marfan syndrome and the like disorders. The dissection risk is very low in childhood, but increases once adolescence is reached. Median age of type A or B dissection is about the same, around 35 years. Sex plays a role, with men on average being at a higher risk, also because they have larger aortas. As you can see in these graphs, the risk for dissection is not always highest in men in all age categories. Higher blood pressure or hypertension puts you at an increased risk for these complications, as do some lifestyle factors such as smoking, illicit drug use, and certain sports, especially of the heavy weightlifting type. Pregnancy is another known risk factor for aortic dissection and requires careful monitoring. Overall, it is important to know that with adequate management and treatment, the risk for aortic dissection in patients with Marfan disease is very low. There is a tendency for increasing rates of type B dissection in recent years, and this is probably related to prolonged life expectancy in patients with these disorders. Now, aortic valve regurgitation, or aortic regurgitation, is a condition that occurs when your heart's aortic valve doesn't close tightly. In patients with a dilated aortic root, stretching of the annulus, or the ring into which the valve leaflets are suspended, is a major cause. Prolapsing leaflets caused by increased fragility is also possible. Aortic valve regurgitation allows some of the blood that was pumped out of your heart, so out of the main pumping chamber or the left ventricle, to leak back into it. The leakage may prevent your heart from efficiently pumping blood to the rest of your body, and as a result you may feel fatigued and short of breath. Aortic regurgitation may be an indication for surgery, either in the setting of aortic root dilatation or after having had previous valve-sparing aortic root replacement. Mitral valve prolapse, as shown in this video on the right side of the slide, is a situation where you can see that the valve between the left atrium and the left ventricle, so on the left side of your heart, is thickened and is what we call prolapsing, meaning that it bulges towards the left atrium when closing. Mitral valve prolapse as such will not cause any symptoms, but it may be associated with mitral valve regurgitation or leakage, in which case, again, as is the case with aortic valve regurgitation, part of the blood that is pumped into your heart will go back to the lungs, and this may also cause fatigue and dyspnea. Mitral valve prolapse is part of the systemic score of Marfan Syndrome, and it occurs in approximately 50% of the patients with Marfan Syndrome, with an increasing prevalence with age. It is a little less prevalent in the setting of Lewis-Dietz syndrome. Some patients may manifest significant mitral valve prolapse and mitral valve regurgitation without much aortic root dilatation, so both entities may go independent of one another. Let's now move to treatment of these cardiovascular manifestations, starting with treatment of aortic root aneurysm and dissection. As already mentioned, a type A aortic dissection is a surgical emergency, which is, even in the most experienced hands, a technically demanding and high-risk procedure with high mortality rates. To avoid this situation, elective prophylactic aortic root surgery is necessary, which is still major surgery, but with much lower and acceptable mortality rates. Thresholds for surgery vary between 45 and 50 millimeters, depending on the underlying gene defect and on the aortic growth rate. More than 5 millimeters per year will require earlier intervention. Surgical procedures include removal of the aneurysm with a valve-sparing procedure or with concomitant artificial valve placement, which may be a bioprosthesis or a mechanical valve. Patients in whom the diameter of the aortic root is below 45 millimeters or patients with a type B aortic dissection require medical treatment. The overall aim of this treatment is to lower the blood pressure and to decrease the growth rate of the aorta. The most commonly used drugs for this purpose include beta blockers and/or angiotensin receptor blockers. Important to know is that medical treatment will continue after aortic root surgery. In case of a type B dissection, with rapid growth of the vessel or a large diameter, or with abnormal flow to vital organs, surgery of that specific part of the aorta will also be required. When mitral valve prolapse is associated with significant mitral valve regurgitation, surgery will also be required. 5 to 12% of patients will require what we call primary mitral valve surgery, meaning that they require surgery of the mitral valve independent of the aortic root, and 20% of the patients undergoing aortic root surgery will also have mitral valve surgery, so concomitant with the aortic root replacement. This may be indicated when the mitral valve regurgitation is more than grade 2. In most cases, surgeons will try to repair the valve, but in some cases, replacement with a prosthesis will be required. Some additional cardiovascular features to take into account in the setting of Marfan syndrome and related disorders include arrhythmia and cardiomyopathy, which are most often related to valvular dysfunction. Aneurysms and dissections of the aortic branch vessels may occur. These are less common but possible in Marfan syndrome and are more prevalent in Lewis-Dietz syndrome and vascular Ehlers-Danlos syndrome. Now, to end this introduction, just a few words about follow-up of cardiovascular manifestations. The key study in surveillance is echocardiography, which will allow imaging of the aorta, the heart valves, and heart function and dimensions. Complementary studies include scanning using either magnetic resonance imaging or CT scanning. In this flow chart on the right side of the slide, you can see a proposal for these imaging studies. All patients should undergo a baseline echocardiography and a baseline scan, and based on these findings, subsequent studies will be scheduled, which is also depending on whether you had previous surgery or not. And either annual or 6-month visits will be scheduled with echo, and usually more extended intervals will be used for the scanning. Okay. Okay.
Just 1 second. I'm let me bring this out here. Make sure we're. See if we can get us all in the screen here. It's Zoom's kind of fighting me a little bit. Come over here. It doesn't look like it's actually showing our video. It's just showing a gray box.
Well, maybe while you are looking for it, Angela, we can already start with.
Yep, go right ahead.
Okay.
Go right ahead.
Great. No, it's okay. I think you're there. It should be on the next one, the first question. Okay, there we go. Okay, so as we said, there will be a lot more information given with these questions. And the first question that we would like to answer is there any pain in the chest area associated with an enlarged aorta? So is an aneurysm and not a dissection painful?
So as Dr. Debakey mentioned, aortic dissection is almost invariably associated with very severe acute pain, usually of the chest and or the back, depending on the location and the degree that it spreads. But unfortunately, aneurysms are not symptomatic, and that can create a clinical problem. If a person doesn't know that aneurysms run in his or her family, or doesn't know that he or she has an aneurysm, there won't be any symptoms unless and until there is a dissection. And this is a particular problem in people who have what we call non-syndromic aortic conditions. In other words, not Marfan syndrome, not Lewis-Dietz syndrome, not vascular EDS, because there are no clues in the rest of the body that an underlying aneurysm might be present. Okay, next question. Angela, can you advance the question?
There we go. Sorry.
That's okay. All right. So the second question is, does severe scoliosis or pectus excavatum affect the aorta?
Yeah, well, the answer, the quick answer to this question is no. There's no evidence that these skeletal abnormalities will affect the aorta. However, it needs to be taken into account that having a severe pectus excavatum or severe scoliosis may compress the lungs and decrease your lung volume and may evidently cause symptoms of dyspnea. It may also cause some displacement of the heart within the chest. So whenever chest x-rays or other scans are taken, you can clearly see that the heart may have moved a little bit due to these pectus deformities, but it will not affect the aorta. Okay, so the next question is about someone having 2 aunts and a brother that died of aortic dissection. And the question is, does that mean I have Marfan syndrome?
So the answer is no. There's clearly some aortic abnormality that's running in the family, but there are a number of different potential explanations. So if you advance to the next slide, right. So here are the diagnostic criteria for Marfan syndrome, which would be certainly one of the considerations. And it's a bit of a busy slide, but basically what it says is that if there is a family history present, well, let me go back. There are some cardinal features, and they include an aortic aneurysm or dissection and lens dislocation, or ectopia lentis, and also an underlying fibrillin 1 mutation. So the other cardinal feature is a systemic score of at least 7. So if we go to the next slide. This is what is a systemic score calculator, and you can find this on the marfan.org website. And basically, in brief, what it reviews is some of the non-aortic features that may be associated with Marfan syndrome. And since many of these features can also be found in the general population, there's no single one that's diagnostic of Marfan syndrome, but some are less common in the general population, and therefore they have a higher value. So for instance, if you just look at the first one, the wrist and thumb sign or long spindly fingers, arachnodactyly, they are much less common, and so they have a value of 3. A pectus deformity, caved in chest excavatum, is relatively common, so it only has a score of 1, whereas the carinatum or the pigeon chest has a score of 2. So basically what we do when we're trying to see whether Marfan syndrome is the underlying cause of a familial aortic condition is to go through this laundry list and add them all up. And if the systemic score is at least 7, then that constitutes a cardinal feature. If Marfan syndrome cannot be diagnosed in your family, then we consider the other conditions. If there are no non-aortic features, meaning that it's non-syndromic, then we consider it to be familial thoracic aortic aneurysm and dissection. So the next question, I had a dissection at 4 centimeters, not in the danger zone for Marfan. Any other predictors on the horizon?
Yeah, so to answer this question, it is very important to know at which part of the aorta the dissection took place. So there's some difference in dissections occurring in the ascending and in the descending part of the aorta. The limits or the risk thresholds in the ascending part are a little bit better defined than the ones in the descending part, and we tend to see more dissections in the descending aorta at slightly lower diameters. What is also important in this setting is what gene defect you have. So there's increasing knowledge about differences between the various genes that are involved in these conditions. So fibrillin-1 is the typical gene for Marfan syndrome, but then you have the TGF-beta receptor genes and all other genes involved in TGF-beta pathway in Lewis-Dietz syndrome. And depending on what gene is mutated, the risk for having a dissection at lower diameters may be different, and this needs to be taken into account. As we already mentioned, the growth rate of the aorta is another common condition that can cause earlier dissection. If you have an aorta growing at a faster pace, then this indicates that there's some instability, and there's an increased risk for dissection. So that needs also to be taken into account. Of course, as also already mentioned, blood pressure plays a role here. People with high blood pressures that are not under control with treatment, even in the absence of any genetic condition, are at risk for developing dissection. And then some lifestyle issues as smoking and certain drugs also can put you at an increased risk for developing dissection. Family history of dissection, and especially if there's cases in the family who have had dissection at lower diameters, then you are also considered as having an increased risk. And then there's some, apart from these factors that I mentioned, there's still many people who do not have any of these factors, and there's ongoing research to define if we can have more specific clues, and there's some ideas about genetic modifiers that may play a role, biomarkers, so factors that can be screened in the blood, and then also mechanical properties or elastic properties of the vessel. So looking for elastic properties of the aorta with specific imaging techniques may also help us to better define this. In relation to imaging, tortuosity of your vessels also plays a role. So if you have very tortuous aortas or branching vessels, that may also be a risk factor to take into account. So there's a number of risk factors. It's a multifactorial thing, the risk for dissection, and all of these need to be taken into account. Okay, so the next question, or it's three questions related to the same topic, is how important do you think genetic testing is if a diagnosis has already been made clinically? And do you have to have a definite genetic abnormality to confirm Marfan syndrome? Can you have Marfan syndrome without confirming the mutation? And is genetic testing definitive?
Right. So as Dr. Debacker mentioned, genetic testing can be very important because it may not only clarify the diagnosis, but in so doing, alter the potential therapies. So the criteria for Marfan syndrome that we just reviewed allow us to make the clinical diagnosis of Marfan syndrome without necessarily documenting an underlying fibrillin-1 mutation. However, I think most of us would agree that it's important to confirm with the genetic testing. And one of the reasons for that is that when Loeys-Dietz syndrome was first diagnosed, a lot of patients who were previously thought to have Marfan syndrome were actually reclassified as Loeys-Dietz syndrome. They're kind of kissing cousins with a few distinctive differences. So the bottom line is it's best to have genetic testing done. In terms of whether the genetic testing is definitive for the syndromic conditions, that is to say Marfan syndrome, Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome, genetic testing is fairly definitive. At least probably 95% of people will be detected to have a pathogenic mutation. Unfortunately, in the non-syndromics, the familial aortic aneurysm and dissection conditions. We don't yet know all of the underlying genetic abnormalities that can exist. And so when we test all of the genes that we know so far to have been found, we only find an abnormality in maybe about 25% of people. So we need to continue to evaluate that group and to identify more underlying genetic abnormalities. Nowadays, I think a very common useful reason to get genetic testing is for family planning. So now we'll move on to medical treatment. Which medicine, atenolol or losartan, is better? Has any research recommended a specific medication? Are there any risks to taking both atenolol and losartan? And what about an ACE inhibitor as opposed to a beta blocker?
So this is a very important and very well debated issue about medication, and so far what we need to emphasize is that both beta blockers and angiotensin receptor blockers have shown a beneficial effect in a number of studies that have been published, and this is the case, I must also emphasize, for Marfan syndrome. So drug trials thus far have focused on Marfan disease, and with the other conditions such as Lewis-Dietz syndrome, there's a lot less evidence at the moment. But the evidence in Marfan syndrome is that beta blockers and angiotensin receptor blockers, among which losartan is the best known, have similar beneficial effects. The experience with beta blockers is extends a lot longer. There's been beta blockers have been used for more than 4 decades, regarding the combination of both drugs, there's also been trials done with the combining atenolol and losartan. And this has shown benefit in some studies, not in all studies, but there's definitely no risk in taking both these drugs. On the contrary, I would say there's in some cases it may be recommended to take both atenolol and losartan. With regards to ACE inhibitors, so these are of the same family of the angiotensin receptor blockers, so of losartan, but same family, but not exactly the same. The evidence with ACE inhibitors is less than with the angiotensin receptor blockers. They are known for their antihypertensive effect, so definitely to treat hypertension, ACE inhibitors have a formal role. In that way, they can be used. But as said, the evidence is a little less strong. What is known is that starting therapy at an early age, so as soon as you are aware of the diagnosis, or at least as soon as your aorta tends to go up, that proves most beneficial. And if you can just show the next slide, Angela. Yeah, so this is a graph from the important PHN trial. So this was a trial that was comparing atenolol and losartan in a pediatric age group. So in pediatric Marfan syndrome patients, over 600 patients were enrolled in this trial. As you can see, the lines of both drugs are going the same way. There was no significant difference between atenolol and losartan. Again, a younger age at enrollment indicated a greater risk, indicating that starting in an early stage is definitely beneficial. Okay, so still related to this, the next question is, I just switched from atenolol to losartan. What are the differences?
Right. So atenolol is in a class of drugs known as beta blockers. And I think the easiest way to think about beta blockers is to say that they block adrenaline receptors. And so basically they're anti-adrenaline. So as everybody knows, when you have an adrenaline surge, your heart rate goes up, your blood pressure goes up. So taking atenolol will blunt both of those effects. Losartan, in contrast, is primarily, at least historically, used as an antihypertensive medication. So it may lower the blood pressure, but it won't affect the heart rate at all. As Dr. Debacker said, we have the most experience with atenolol, although at least in the case of patients with Marfan syndrome, they may be equally effective in slowing the rate of aortic root growth, although in comparison one to another, neither one has been shown to be clearly superior at preventing aortic dissections. Part of the answer to this question also depends on what the questioner's underlying aortic condition might be. We definitely have most experience in comparing drug classes in patients with Marfan syndrome, and to a lesser extent in Loeys-Dietz syndrome. But a lot of the information that we've gained from Marfan syndrome treatment, we extrapolate to other conditions. And while that's probably a reasonable and cautious application, we don't yet have definitive trials, particularly for people who have non-syndromic aortic conditions. Next question, my aorta was up to almost 4.0. Now with the atenolol and losartan, I'm told I'm entirely normal. How long can that hold?
Yes, so to answer this question, I don't think anyone can say that in patients with Marfan disease or with related conditions that the aorta can be considered as entirely normal. There's always some fragility of the vessel, even when the diameters are well below 4 centimeters. So I would not consider an aorta in these conditions as a normal aorta. And what also needs to be taken into account that even in patients who do not have genetic conditions, that aortic growth is something natural. It's something that occurs with age. So on average, an aorta will grow about 1 millimeter per decade, a little bit faster in men than in women. And the growth rate in patients with genetic conditions is a lot faster. It's actually almost 10 times as fast. It will go up to 1 millimeter per year in some patients, especially in those patients who are not treated. And as Dr. Roman has explained, the aim of medications or of drugs is to lower the growth rate of the aorta. And with treatment, you can go down to about 0.3 to 0.5 millimeters per year. So still faster than in a normal aorta, but you can definitely decrease the rate of growth of the aorta with these drugs.
I'd like to just add one other comment to what Dr. Debacker has said, and that is that there's not a single upper limit of normal. It's really a function of age and body size and also sex. I mean, as Dr. Debacker said, the aortic root normally grows with age, but I'm a relatively small person, and so an aortic root of 4.0 would be enlarged for me, but for a tall man with Marfan syndrome, it might actually fall within the normal range. So it's always important to consider the absolute diameter relative to these other features, age, body size, and sex.
Yes, so the next question is, I'm dissected from neck to the iliac arteries with a dissection in 2007 and still get sharp pains in the right shoulder blade area. And the doctors say that this is a muscular problem, so ignored, and therefore the doctors have changed the drugs over the last 2 years. I was having severe fatigue problems, a low pulse, extreme blood pressure variations, dizziness and headaches. And with the last one, I was getting very edgy on top of the rest. So I went off the last one, which was valsartan. So I do not take any drugs anymore. I feel better than ever, but I'm concerned that this is not so smart for my aorta. What are the suggestions?
Okay, so I'm assuming that this dissection is probably a type B dissection or a type 3 dissection, meaning that it started after the arch, because otherwise you probably would have had emergency surgery. And these type B dissections need to be monitored very, very carefully because they can grow over time. It's really important to limit the growth of the dissecting aneurysm to keep the blood pressure as tightly controlled as possible. Of course, we don't want to produce debilitating symptoms from the medication, and so sometimes it has to be a very careful titration of what the blood pressure and heart rate are and what the symptoms are. So unless you have a very, very low blood pressure without any medication, I think it would probably be important to be on some sort of medication, but there may be a little bit of trial and error to figure out exactly what that medication is. Now, sometimes what we'll recommend is for a person to actually check his or her blood pressure at home, because it may be that the blood pressure in the doctor's office is normal or low normal, but for the 99.99% of the time that you're not in your doctor's office, it's even lower, and it's possible to be over-medicated. So the next group of questions relates to imaging. And so first couple of questions. What is the likelihood that the aorta can shrink? My brother had a measurement of 5.0 2 years ago, and now his measurement is reading at 4.2. Second question, I had an emergency type A dissection in February 2016. I measured 4.3 afterwards. In 2017, I measured 4.2. A week ago, I was 4.0. Can the aorta get smaller? Are these results possible? At the John Ritter Symposium, I could swear the surgeon says you can't decrease in size. My doctor said I could even skip getting scanned next year.
Okay, so yeah, the brief answer to this question is the aorta does not shrink, and an aorta, as we have been explaining, is growing with age, and is not going down in anyone. So shrinking is not something that we take into account. But what is very important in these questions is that when measuring the aorta, you really need to be very careful that it is done with the same technique, and preferably by the same operator each time that your aorta gets measured. So you will obtain, there's differences, this is well known, there's differences between measuring the aorta on echo, measuring the aorta on a CT scan, and measuring the aorta on an MRI. And even using the same techniques, some we call it inter-observer. So if you have the same measurement and done by two different people, or even intra-observer. So if you have the same patient and you measure twice on different images, you may obtain different values. And in echo, typically differences of 2 millimeters are accepted as, well, standard differences that we can obtain with these measurements. So if you are going to compare a measurement of this year with the previous,
Mary, are you still here?
Yes, I am.
I think we lost Julie. Seems like her video or her audio just went out.
Oh, okay. Well, until she comes back on, I'll go over, if you could advance to that next slide.
Yep.
Because it very nicely goes over how differences can be explained from different imaging techniques and using different measurement techniques. So if you look at the top left, you can see that the aorta, number one, has a wall, and number two, it pulsates as the blood is ejected into the aorta. So it depends on whether you're taking the measurement when the aorta is expanding as it receives the blood or when it's at rest during diastole. So we tend to want to take diastolic measurements to eliminate that variability due to pulsatility. If you look at the top column over to in the middle, you can see that you can measure inside the wall or you can measure outside the wall. If you look at the middle section, you can see that it's ideal, I hope you can, I can see this, I don't know if you can, to measure perpendicular to the wall as opposed to oblique, which would give a larger measurement. And then finally, if we look at the lower left, you can see that the sinuses of Valsalva have these outpouchings. And in general, you want to measure from one outpouching to the other outpouching as opposed to from one outpouching to where the valve leaflets meet. So these are all of the technical reasons that there may be differences in measurements. So the next question, how often should an adult person with Marfan syndrome get an MRI? Well, Dr. Debakey already went over this a little bit in the introductory presentation. And if you look at this figure, in general, once the diagnosis is first made, and most frequently that's with an echocardiogram, we want to get a baseline MRI or CAT scan so that we can look at the full extent of the aorta to see if there's any involvement elsewhere. Marfan syndrome most commonly affects the aortic root, and we see the aortic root really well with the echocardiogram. So getting this more panoramic view is just to make certain that there's no other part of the aorta that's involved. If there is no other part, then as indicated in this algorithm, it can be delayed until maybe 5 years or so. If there is involvement beyond the aortic root and we don't see it on the echocardiogram, then it would be reasonable to scan more frequently. If surgery has already been performed and/or if a dissection is present, then we would more frequently go to the CAT scan or the MRI. If the MRI images are good, I prefer to use that because you avoid the radiation that's involved with CAT scanning. Depends on diameter and surgical status. I think we already went over that. Okay, I guess Julie's not yet back with us. So in terms of surgery, the first question is, I am 68 with a 4.9 centimeter aneurysm that grew suddenly over this past year. My question is, other than being alive after surgery, will I notice healthy aspects in 6 months post-surgery? Also, can I go forward without the beta blocker, which I could not tolerate? Well, again, part of the answer to this question is what the underlying aortic condition is. If it's Marfan syndrome, 4.9 would not necessarily be a threshold, but if it's grown and that growth has clearly been documented, then it's probably time to have the surgery done. Most people, it depends on what shape you're in before the surgery, but if you're in good shape, you may feel back to normal as soon as 3 months after the surgery, but certainly by 6 months, everything should be okay. In terms of treatment afterwards, unless the aneurysm is due to bicuspid aortic valve, we tend to want to continue therapy even after the aneurysm has been removed. And that's because even though most of the aneurysms in Marfan patients occur within the beginning part, the aortic root, there still can be enlargement elsewhere, and there is about a 10% rate of a type B dissection involving the descending aorta. And in theory, medical therapy, be it a beta blocker or an angiotensin receptor blocker, may help protect the remaining aorta. As I mentioned before, sometimes it's a matter of trial and error in terms of whether you're on the right beta blocker or need to go to a different medication. One thing that I will say is that I tend to prefer atenolol to the other beta blockers because it doesn't cross what we call the blood-brain barrier. And so what that means is that it doesn't get into the central nervous system and on average doesn't tend to cause as much fatigue as some of the other commonly used beta blockers like metoprolol. But bottom line, you should try to find some medication post-op that you can tolerate.
I think we have Dr. Debakey back.
Okay.
Yes, exactly. I'm so sorry. I don't know what happened. There's something wrong with the internet, but I'm
happened.
Okay, welcome back. So why don't we go to the next question, and we can toss that one to Julie.
Doesn't want to click.
Okay, so this question, I got a type B dissection and now descending aorta growing and at 4.7. My ascending aorta and aortic valve were replaced 11 years ago, because of an aneurysm. At what size should I go for surgery?
Yes, so yeah, first of all, I have not managed to set up my video again, so sorry for that. But to answer the question, so for Marfan patients with asymptomatic chronic dissection, the general recommendation for repair of the descending aorta is when the diameter exceeds 5.5 centimeters, so it's a little higher than in the aortic root. Or again, and here comes the growth thing again. So when the aneurysm diameter expanded with more than 5 millimeters within the last year. So it's a bit similar to the aortic root in the descending part of the aorta. The absolute diameter plays a role, but maybe even more important here, the growth rate at which the aorta grows is playing a very important role in deciding on the indication for surgery. Okay, so we move to the next question. If the aorta is repaired, won't that cause the pressure to rise and blow others out? So in the more distal part of the vessel.
That's a really important question, and I don't think that we know the full answer to this. And it's actually an area under investigation, including at Cornell, where I work. You know, in theory, the shear forces may increase as the blood goes from a fairly rigid conduit into the more pulsatile aorta. But I think we just don't yet know whether that is actually related to problems with aortic aneurysms and/or dissection developing in the more distal aorta, that is to say the descending thoracic or abdominal aorta. In any event, we do know that it's important for the aorta to be repaired in order to avoid aortic dissection, but we just need to do more research to better answer this question, but it's an excellent question. Next question, what is the likelihood of a second aortic repair surgery after having surgery at a younger age? And as a corollary, what is the likelihood to have subsequent aortic dilatation surgeries I had surgery to repair my 6-centimeter aorta in 2010 at 18. Can I expect to have an additional surgery on the adjacent section? Also, will that repair section last a lifetime or likely need repair later on?
Okay, so this is also an important question. First of all, so the repaired section of the aorta will normally last, well, like forever is maybe a hard word, but will last for a lifetime. What is important if you had surgery for aortic root aneurysm is that your valvular function needs to be monitored. So we have mentioned in the introduction that you will have had either a valve sparing procedure or a procedure by which a prosthesis is inserted in, or the native valve is replaced by a prosthesis. So valvular function needs follow-up and may require intervention in some cases. And there's been a number of studies looking at this, and the freedom from reoperation at the aortic valve is low, but it's not zero. So it's about the same in patients having had what we call a Bental, so where there is a prosthesis, and what we call a valve sparing procedure. It's about 92% of patients who will not have had a reintervention, so a little less than 10% who require intervention. And then regarding the adjacent sections of the aorta, there is a lifetime risk of developing aneurysms and dissections of the more distal parts of the aorta. And it's hard to put a number on that, to say how many patients will require surgery of the distal parts, but evidently, if you had surgery at a young age, your risk will go up, because there's still a lot of years to go, and the younger you had your first surgery, the higher your risk for having subsequent procedures in the more distal parts will be. So again, necessitating lifelong monitoring of these distal parts of the aorta. Okay, so I think this is the yeah. So this is what I've been talking about. So second aortic surgery in the more distal parts of the aorta is necessary in about 8 to 50% of the patients. And we already mentioned this as well. If you had dissection of your more distal part of the aorta, you are at an increased risk for having new surgery. Hypertension is a risk, and we always come back to these lifestyle factors. So smoking, for example, is not a good idea. So the next question is, my grandson had the aortic surgery at the age of 14. Does he need checkups every year?
Well, this is a very easy question to answer. Yes. I'm curious to know what your grandson's underlying condition is, but the fact that he required surgery at a relatively young age means that it's critically important for the operated part of the aorta to be followed, as well as the rest of the aorta. So checkups would include both imaging, primarily with echocardiogram, but perhaps periodic MRIs, depending on what the rest of the aorta looks like, and certainly medical therapy with blood pressure and heart rate control. So our next section is arterial disease. And so it's important, just by way of clarification, when we talk about arterial disease, as Dr. Debakey said, the aorta is the biggest artery in the body, but when we talk about arterial disease, we're usually talking about non-aortic arterial disease. So disease in arteries other than the aorta. So is arterial disease common in Marfans?
Okay, so so aneurysms, when we talk about arterial disease, we talk about aneurysms or dissections. So aneurysms of the various peripheral vessels, and as Dr. Roman mentioned, these may be the iliac arteries going to your legs, the renal arteries, or the subclavian arteries. And these occur in up to 20% of patients with Marfan disease, especially in patients who had previous aortic surgery. So it's 20% about in patients who did not have surgery. I made a mistake here. I'm sorry for that. But the prevalence goes up to 43% in some studies in patients who have had previous dissections or surgery. So apparently having had procedures or dissections in the aorta put you at an increased risk. Up to 20% of these lesions, or these arterial lesions, may require surgical intervention. I'm going to switch back. Yeah, can you hear me?
There's a lot of feedback on that way.
I had some technical assistance, so
Okay.
okay. So I was talking about the arterial disease, and I just wanted to mention that intracerebral aneurysms and dissections are uncommon in Marfan syndrome, but there is an increased risk for spontaneous coronary artery dissections in this disease. So these are dissections that may occur at the level of your heart. And these have been reported in patients with Marfan disease and related conditions. So the next question is also related to this, and it is, what about a patient with Lewis-Dietz syndrome and has had dissections in the heart other than in the aorta? Is that a higher risk factor for aortic dissection later? And do dissections other than in the aorta happen often in Lewis-Dietz syndrome?
I'm not entirely certain what is meant by had dissections in the heart, but maybe that's relates to other arteries. But about 20% of patients with Loeys-Dietz syndrome may have involvement of arteries other than the aorta, including in the brain or the intracerebral arteries. And for that reason, it's really important to be very aggressive with blood pressure control. In addition, whenever anyone has had a dissection, it means that there has to be continued surveillance because that dissection could spread either forwards or backwards, and that dissection can grow and perhaps require therapy. So next question. If you've had other dissections, coronary, etc., are you at higher risk for an aortic dissection?
Yes, well, so this question also relates to the previous ones, and we have already mentioned that having had previous dissection in other arteries can gives you an indication that there's more fragile vessels and that you are at an increased risk for dissections in other arteries. So to specifically answer the question, a higher risk for an aortic dissection, that is very difficult, but because I don't think that there's many data about this, but what we can say is that arterial dissections in different vascular beds tend to cluster. So if you've had these events in the past, then you are definitely at an increased risk for having dissections in other parts of the body, including the aorta. Okay, so then we move to the sports section, which is also a very important section in these conditions. And the first question is, my cardiologist have restricted me to A1 sports, which makes it hard for me to watch my weight, and impossible to participate in high school sports that don't even involve that much contact, such as baseball, and some involve no contact, and yet I'm not allowed. So I really want to play sports, even after I'm aware of the fact that I'm at risk for dissection. So what should I do? Yeah, P.S. I'm taking a daily dose of 50 milligrams of losartan.
Okay, well, there's actually a lot to say about sports in these conditions. And the European Society of Cardiology has just today released new guidelines for sports activities in patients with cardiovascular diseases, including aortic aneurysms. But just in terms of a broad overview, in general, we prefer that people do aerobic exercises as opposed to isometric forms of exercise. That would be weightlifting. And the rationale for that is that when you're lifting weight, you may do what's called a Valsalva maneuver where you strain and there's a precipitous increase in blood pressure as opposed to a gradual increase when you're doing aerobic forms of exercise. We recommend against contact sports because people with aortic aneurysms, their aortic tissue is more fragile than normal. And so if you're hit with a ball or by another person like this on your chest wall, there may be what we call a coup counter coup, and that could precipitate an aortic dissection. So for instance, with baseball, you know, even if you are just in the outfield, you don't know if you're going to slide into a base and hit somebody, or a base runner is going to hit you. You don't know if you're going to miss that ball and that ball is going to hit your chest. We recommend against competitive sports because when we compete, our adrenaline goes up. And that's something that we want to avoid in terms of high blood pressure and fast heart rate. And that's one of the potential reasons that atenolol might be preferable to a drug like losartan, because it does lower the heart rate, slow the heart rate with exercise. And so in a way you can, quote, get away with more in the way of exercise. One underlying principle is that it really is important to do some form of exercise. You shouldn't be a couch potato, and you just need to figure out what's the best one for you. But there are a number of things that one can do to keep in shape and things that are safe. And these include walking, non-competitive recreational jogging, swimming, bicycling, those sorts of things. This is a guideline from the American College of Cardiology, which is the US organization that has propagated guidelines. And they can be useful in terms of looking at what is and is not allowed. I'm not a golfer, and so I forgot to mention golf as something that one might be able to do. So. Next question, would a person diagnosed with Marfan have a lower recommended maximum heart rate than a typical person? What is the highest heart rate somebody with FTAT or Marfan should experience? Walking up a hill increases heart rate, yet it is still walking.
Yes, so as Dr. Roman mentioned, that there's in deciding what sport to do, you need to consider the static and dynamic components. But then heart rate is something that many people will follow when they practice sports. There's these fancy smart watches and whatever that have that everybody has these days. So it's definitely so that patients with Marfan syndrome have a lower recommended heart rate, but it's not easy to put one size fits all rules here. So this is a very individual thing, and you need to discuss this with your physician. Your heart rate will depend on your level of physical capacity. It will also depend on your age. It will depend on your sex, on your body composure. So you really need to check with your physician what heart rate is the best for you. What also needs to be taken into account is that beta blockers, so atenolol and drugs like that will decrease your heart rate and will typically decrease your heart rate when exercising. So your maximum heart rate will be influenced by these drugs. As a general rule, just to put one figure to it, there's a general rule that says that you should not exceed 120 beats per minute with your heart rate. So, but again, discuss this with your doctor and ask for individual advice on this issue. I think. I don't know if we have missed one, Angela. There was a. Oh yeah, so there's two questions on this on this slide. What is the highest heart rate? Yeah, what is the highest heart rate? And I had another question.
What's the next slide?
Yeah, maybe we
yes,
should.
This is the. No.
So there, yeah, then this is the next one. There's a general exercise recommendation for people with Marfans, which is to use, which used to prevent people with Marfan syndrome from exercises altogether. Can you change the recommendation to look at individual cases before stopping a person from exercising altogether?
So this is very simple. There isn't such a recommendation. It's really important, as I said before, to not be a couch potato and to exercise. To keep your body in good shape, to keep your mind in good shape. But what's best for you may need to be determined. But there's no prescription against exercising altogether. Next question, I'm currently living in Eastern Europe and am post-aortic replacement surgery in November of 2015. I'm concerned with the levels of exercise I'm able to do as I've been experiencing some issues such as pain and shortness of breath. What sort of limitations do I have?
Yeah, so in this case, I think complaints like pain and shortness of breath need a medical checkup. So if you have not had a checkup recently, you should go and see your doctor to exclude medical conditions such as valvular problems or issues with your cardiac function. If those issues have been checked and are excluded, your exercise levels should be the same as in people without surgery. So there's the only distinction that is made here is that in people who had previous aortic dissection, the restrictions are a little more strict than in patients who have not had dissection. So if you had elective replacement of your aortic root and just that, then the exercise recommendations are similar as to the ones that apply prior to the surgery. So we are getting to the end with some miscellaneous questions. And the first one here, is there any research or evidence to support the use of collagen supplements in people with Lewis-Dietz syndrome or other connective tissue disorders?
No, we're not aware of any evidence to show a benefit. Likewise, we're not aware of any evidence to show a damage. So I think it becomes an individual decision whether you want to take a supplement that could potentially have bad side effects down the line, but could potentially have some unproven benefit. Next question, aortic root replaced with 3 centimeter Dacron tube 14 years ago is now 3.6 centimeters. Is that expansion of graft, must be graft, normal? I'm an elect valve sparing root replacement, patient 8 years post-surgery. How much research data do we have on the longevity of the Dacron graft and aorta that is used to replace the aortic root tissue?
Okay, so it is known, so dacron is a very durable tissue and dacron graft, so the material that is used for the replacement of the aortic root is a very durable material. So there may be some slight extension on the imaging studies in patients who have had such grafts, but these are clinically not very relevant. It is known, and I think we have already mentioned this, that an aortic root replacement is a very durable procedure with regards to your aorta or to the aortic root. But what needs to be checked, as we have mentioned in the previous questions, is one thing, your aortic valve function needs to be checked regularly. And then the other thing that needs to be monitored is the distal part of the aorta. So in case of an aortic root replacement, you will only have the proximal centimeters of the vessel that will be replaced, and the rest of your aorta is left, is native aorta. And regular surveillance of these more distal parts is required to check if there's no issues over there. I think this was the final question that we have prepared, but I don't know, Angela, if you have other questions.
So there are a few others that have come up, but paying attention to the time, I want to kind of move us into wrapping up here. If you have a question that you would put in the Q&A or anywhere else, we wouldn't have seen it if it wasn't in the Q&A, but if you have questions and would like to see them answered, please do submit them to marfan.org/E3ask. We are experiencing a good amount of volume of questions through that website, but you know, we'll get you connected to the answers that you need. That's what we're here for. We just ask for a little bit of patience as we work through all of the questions that are coming in after sessions such as this one. Also, we very much love your session feedback. So whatever you're viewing this session in, whether it be on your phone, on a tablet, on your laptop, right below the window where you're viewing, there should be a Rate It button. And if you would just click that link or button, it takes less than a minute to submit your feedback. And we are so grateful for your time in giving your feedback on these sessions. It helps us plan future things that can best serve our communities and the people who need to hear this information the most. If you have not yet visited the exhibitors in our virtual exhibit hall, we encourage you to do so. There are additional resources in there that may be helpful to you as you navigate life with a connective tissue condition. And if you are not connected yet in HUVA to the community, either via the discussion boards, you are definitely missing out. There are people from all over the world connecting on both medical topics and just living life with a condition that other people in the community understand. So I encourage you to hop over there and see who you can meet or see what information you can learn from people in our community. And then if you are sharing this information online, we encourage you to use our E3, hashtag E3 Summit 20 with your posts, so we can share with the world where all and what all is happening out there as we participate in E3. Thank you so much to Dr. Debakey and Dr. Roman. Your time and expertise on this has been so valuable. This has been a wonderful presentation. We did get a few questions in the chat about being able to see as you know, when you have a slide or a chart with a lot of information on it, sometimes it can be a little difficult to see. So we will be posting some of those. We'll link to some of them, if not the whole presentation. I'll talk to you both later online, and I will get it posted in the chat for this session for later on if you want to come back on Monday and download it from there. So with that, do either of you have any last remarks you'd like to share?
No, thank you all for being here and for your attention, and I hope this has been useful to you. I think it's a wonderful opportunity in these times.
Yeah, I fully agree, and thank you, Dr. Roman, for wanting to do this together. And I want to apologize for the technical issue that occurred. I had a crash with my computer. I don't know. Anyway, thank you, Angela, for the organization, and I really appreciate being here, and I hope it's been useful. Thank you.
I am certain this has been useful. You two have put in so much time and energy in making this just such a wonderful presentation, and it really came through how much you care about your patients and about those in this community. And we are so grateful to have you as a part of this event and as a part of our community. Thank you so much to you both. Have a good day wherever you are in the world right now, and we look forward to seeing you on your next session during the E3 Summit.
Bye-bye.
Bye-bye.